So first of all, just to go through the differences at birth. So in the antenatal circulation, I'm sure you all know that not much goes to the lungs. So it's kind of all diverted around the body instead. The right side of the heart isn't used as much as the left in the antenatal period. So that is why the pressure in the right atrium is greater than the left. So then you get the foramina valley staying open because the pressure's pushing that over. The right side pressure is higher, because the lungs are filled with fluid basically. So that's quite high resistance for the heart to be pushing against. And obviously this ductus arteriosus is open as well. So that's the connection from the pulmonary artery to the aorta. So anything that does go out the right ventricle is mostly redirected into the aorta then and around the body. So at birth then, as that pulmonary pressure drops, you'll get that foramina valley closing because the left side of the heart, the pressure is greater than the right. So that closes that. Also the ductus arteriosus closes about day 1 or 2. That's important to note when that happens because some of the cardiac lesions are what we call duct dependent. So they're relying on that duct to be open to maintain circulation. So if that closes, then they start to get symptoms of that. So if something happens like day 2, then you're thinking that it was a duct dependent lesion. Also just to note as well, so the foramina valley can persist in some people. It's actually really common. It's about 1 in 4 people in the population have a patent foramina valley. It's usually asymptomatic, doesn't need any intervention. Most people won't even know they have it. It is like a theory that it increases risk of strokes and migraines, but it's not been proven. So far as we know, it doesn't cause any harm. You can close it via cardiac catheter device if you need to, if you think it is causing bother. Okay, so couldn't talk about cardiology without Arizona in it. But congenital heart disease is obviously the most common type of heart disease in kids, whereas adults, it's more ischemic heart disease. Mostly diagnosed with antenatal ultrasound, so it's usually the 20-week scan that you would start to pick things up. If you do see anything, you would then go on to do an echo to fully diagnose it. Fetal echo is also done on babies who are higher risk. So any suspected Down syndrome babies will have fetal echo. Any babies with siblings with congenital heart disease or whose mothers had congenital heart disease will all have a fetal echo done. Quite common congenital heart disease. But 10 to 15% have more than one lesion and also non-cardiac abnormalities. So it's quite highly associated with syndromes and different defects. This is where you might get a few finals questions around this, and I know that we did. Just the different etiology of different lesions, what's connected. Sorry, my camera's in the way. So, maternal rubella is quite a commonly asked infection to know. So it causes that triad in kids of congenital deafness, eye abnormalities such as cataracts, and then cardiac defects, so things like pulmonary stenosis and PDA. Also to note that lupus causes a complete heart block. That is because of the anti-Rho and anti-La antibodies actually cross the uterus and cause complete heart block. And diabetes increases the risk of all of the congenital defects. So just to be aware, that's always a good risk factor to come up with. We don't use warfarin in pregnancy because it can cause patent ductus arteriosus. If an anticoagulant is needed, you would use low molecular weight heparin injections. I kind of highlighted the most of the ones. I'll send the PowerPoint out so you can have, don't need to jot them all down. Down syndrome is most commonly associated with ABSD. So while it does cause ASDs and ASDs and all sorts of other cardiac lesions, and ABSD is the most common one. And Turner syndrome, commonly associated with coarctation, and the others. And then DeGeorge syndrome is most commonly associated with tetralogy of Fallot. So much so that if you find a baby with tetralogy of Fallot, you would always consider DeGeorge syndrome as well. So that's a syndrome of, catch-22 is the acronym. So it's thymic hypoplasia, so get low calcium, cardiac abnormalities, and hypothyroidism. And it's a 22 is the 22 gene deletion. Okay, so as I said before, it does most commonly found on the ultrasound and then completely diagnosed on fetal echoes. But sometimes this isn't picked up. Ultrasounds are tricky, you might not see everything, might not be in a good position. So they can present with just a heart murmur after birth, heart failure, either at birth or a couple of weeks of life. Rarely in shock or cyanosis is just with the cyanotic heart diseases. Just to note as well that you can get an innocent murmur, which is quite common in kids. So something which is soft, short, systolic, asymptomatic, and at the left sternal edge. So you remember it as the 4 S's, although you do have to be a little bit creative. If you hear something like that and it's an unwell child or the child's anemic, because those things can make the murmur more prominent, louder, then you would re-examine them when they're well. I don't think many GPs would be confident in just saying it's an innocent murmur. I think they're all well, and if the murmur's there, then they get referred to a paediatric cardiologist. So the investigations will always be chest X-ray, ECG, and an echo. So those are first line investigations for everyone who you're considering some sort of heart disease. Just to note as well that some murmurs can be absent at birth. So when you do the newborn examination, so mostly you're doing that at only a few hours of life. So some murmurs might not actually be heard then. That's because the pulmonary pressures can still be quite high at birth, and that can take up to a couple of weeks to come down actually. So when the pulmonary pressure is still quite high, right-sided heart pressure is still high because it's still pushing against the pulmonary pressure. So murmurs that you would get because of the left to right shunt, such as like a VSD, might not actually be heard because you're not getting so much of a shunt when that pressure is still really high on the right side. So once that right pressure starts to drop, then the blood flow is going to start going left to right and cause your murmur. Yeah, so just something to do. VSD and PDA are the most common ones that might not be present at birth because of pulmonary pressures are still high. Okay, so another presentation is heart failure. So generally these present with breathless babies, sweating. They won't feed very well because they get so breathless when they are feeding. Recurrent chest lesions and faltering growth is a sign of heart failure, but also with those two things linked, you always want to rule out cystic fibrosis as well. You can get murmurs obviously as well, and cardiomegaly. The signs of heart failure that you'd often see in adults, you don't really see in kids. So you're very, very rarely going to see edema in children. I don't think I did some in paediatric cardiology in Alderhay, and I did not see one edematous child, but plenty had heart failure. So it is more this tachycardia, tachypnea, poor feeding, faltering growth, as much things present in kids. Just to note as well that they can get hepatomegaly, and it can be quite prominent, so it's always worth doing an abdominal examination with a cardiac exam in kids, so always having a feel for the liver. On the examination note as well, make sure you always feel for femoral pulses in babies. So in an examination, like if you were doing, like say an OSCE or LOCAS, so LOCAS you could definitely get a child doing a cardiac exam. They might not obviously make you do femoral pulses there, but just always say that in clinical practice, I'd like to have a feel and check the there. Would you like me to do it today? just pointing out that you're aware of it. So just some causes then. So causes can be split down into when they present with heart failure. So in the neonatal period, so neonate is up to 28 days of life, it's generally left ventricle obstruction that causes heart failure. So hypoplastic left heart syndrome, critical aortic stenosis, or severe coarctation of the aorta would cause it in the first few days of life. After about a week of age / out of the neonatal period, it starts to be due to high pulmonary blood flow. Obviously the lungs weren't built to put up with such high blood flow, and you start to get pulmonary edema, and that's when you start to get symptoms of like breathlessness and poor feeding, things like that. So high pulmonary blood flow happens with left to right shunts. So things like a VSD, AVSD, or really large PDA can actually cause that. So then in older kids and adolescents, so you want to think about Eisenmenger syndrome. I'm not really sure about the pronunciation, but go for it. This is when you have a left to right shunt that goes undetected or untreated, and over time that high pulmonary blood flow causes high pulmonary pressure in the pulmonary vasculature. So that can then actually reverse the shunt as the right side heart pressures go up. So then the shunt reverses from right to left, and that's when you get cyanosis. And they can also get the signs of right heart failure then as well. That's quite severe when that happens, although extremely rare, but it actually is an indication for a heart and lung transplant. So it's quite severe, quite further down the line. Another thing to bear in mind is cardiomyopathy. One you probably get asked about most commonly is hypertrophic, so HOCM, hypertrophic cardiomyopathy. It can be spontaneous de novo, but it can also be familial, and it's autosomal dominant. So it's worth asking always, is there any cardiac history in the family? HOCM, there'll classically be a history of sudden cardiac death in the family. It's just hypertrophy of the left ventricle muscle, and it's so thickened that it just doesn't contract very well, and you're not getting the same systolic pressures. Can get symptoms of feeling like tired, fatigue, chest pain on exercise, but generally it is asymptomatic and cause a sudden cardiac death. So if there's a known in the family, they'll be followed up in clinic with regular ECGs and echoes. They're given beta blockers as medication. They can have surgery, so like septal ablation or septal myectomies if it's really quite severe. Oh, sorry, just one more thing to mention as well. So I said heart failure often presents with tachypnea. Obviously that's not the only cause of tachypnea in the newborn, and it will often it's often a good thing to ask about in exams, differentials of that. So it's worth just having a little look at that. It's not something that I've covered today just because I don't want to spend ages on it, but just knowing a little bit about transient tachypnea of the newborn. So just when there's still quite a bit of fluid on the lungs, is what it says in the tin. It's transient, usually goes within a few hours, days. Common in babies who are born by C-section because they have that fluid pushed out at birth. Other respiratory causes like respiratory distress syndrome due to surfactant deficiency, so more common in premature babies. Meconium aspiration, you might get meconium and go with that would make you a bit suspicious. Pulmonary hyperplasia, which you could get with a diaphragmatic hernia. Sorry, it's saying my internet's a bit rubbish. Let me just turn on my hotspot because I think last time it crashed. Obviously cardiac disease as well can cause it. Infection is another one to bear in mind. So in neonates, you would think of a group B strep infection. So that can be due to maternal group B strep infection. It's a common cause of sepsis in neonates. So signs of tachypnea, other signs of sepsis as well. Sorry, let me just check. Sorry, technical difficulties. Okay, I'm back. Hopefully my internet will not crash this time. Sorry, if I'm going too fast at any point, someone just say as well. Or if you have any questions, just put them in the chat along the way. I know you guys probably know this stuff inside out, so I don't want to go into loads and loads of detail explaining stuff, but if you want me to, I'm more than happy to run through some stuff. Okay, so common cardiac lesions then. So you've got your left to right shunts, which are your most common ones, and the most common of those is the VSD. So with those, the blood's generally flowing from left to right, so you get breathless, and that's because of the pulmonary edema cause. Also because there's not as much output from the left ventricle, so you're not getting as much oxygen around the body, so you can get a bit fatigued, a bit breathless. The right to left shunts, however, cause stenosis, so they're your cyanotic heart diseases, so things like tetralogy of Fallot and transposition of great arteries. So they are more rare, only 5% of congenital heart disease, but just worth knowing about them as well, because obviously they are emergencies, can be incompatible with life. So a quick thing. So this diagram is of an ADSD, because this is one I said was most commonly associated with Down syndrome. So you can see that you've got quite a large VSD there. Also got an ASD, which is also involving the tricuspid and mitral valves. So it's kind of like you've just got massive chambers. Like there's just blood flowing everywhere. It's all mixing. It's easily flowing all around the heart. So these babies are often blue and breathless. There will not be a murmur with this, just because there's so much open blood flow. You know, a murmur is turbulent blood flow, but when there's this much open passage for the blood to flow, it's not really turbulent. You get a murmur. Can present with cyanosis as well. Obviously, can go right to left and a left to right shunt. Generally, heart failure at 2 to 3 weeks of life is how this will present. It's fixed with surgery at about 3 to 6 months. You would normally do it quite early because they can get a lot of symptoms with this. So then the outflow obstruction. So an outflow obstruction in a well child, so they're asymptomatic of it, can be pulmonary stenosis or aortic stenosis. So we'll go through those and the murmurs. Also, just to note that a critical or really severe aortic stenosis can make a really sick neonate. So that can cause neonatal heart failure or circulatory collapse. So obviously it depends on the degree of that. But most typically, outflow obstruction in a really unwell baby is coarctation. So that's what I was saying causes the heart failure in that neonatal period, is the obstruction to the outflow of the left ventricle. Okay. So going through the aortic stenosis first then. So the left ventricle outflow tract is restrictive. Okay. So generally it's asymptomatic if it's mild stenosis, which it generally is in kids. It would probably be picked up as heart failure neonatal period otherwise. So you get this ejection systolic murmur. So that is the blood flow is just so turbulent against this narrowed aortic valve. Okay, so it's just when the heart is in systole and tries to pump blood out, that narrowed opening is what's causing your murmur, the turbulent blood flow going through that. Okay, so you get ejection systolic murmur. So it's upper right sternal edge, so that's the aortic area. Often commonly radiates to the neck as well. So it's always worth having a listen either side with the bell of your stethoscope. maybe not possible in kids, but in older adults, you know, you'd always ask them to hold the breath and make sure you hold your breath with them so that you don't forget to tell them to breathe again. Maybe more common in kids, you might feel a carotid thrill. That would be quite a severe murmur travelling up. Also, classically, you get your small volume, slow rise in pulse. I'm not really sure if you'd pick that up in kiddies. Really severe, as I said, it can cause symptoms such as syncope, reduced exercise tolerance, and neonates with critical and heart failure or shock. Okay, so they have because that outflow of the left ventricle is so narrowed, they're classified as duct-dependent systemic circulation. Okay, so that blood's going from the right ventricle out of the pulmonary artery across the duct into the aorta. So it's just bypassing the aortic valve completely, it's just going another path. Blood will always go the least resistant path. So that may, you know, it's important to keep that duct open in these babies until you relieve that critical aortic stenosis. Okay, so treatment can be with balloon dilatation, so that's just done via the catheter device through femoral or through the wrist, or in more severe cases it may require surgery to do a replacement. Okay, so pulmonary stenosis is also a ejection systolic murmur on the upper left sternal edge. Okay, so these are pretty similar murmurs, just because it's that blood being turbulent against the nose going out. So obviously these will always be, you know, if you hear a systolic murmur, you're always going to say these two. Okay, you're never going to be able to really confidently say from just examination which one it is, although you can have a good guess, but we would always diagnose things on echo anyway. Okay, the pulmonary stenosis one, so in exam questions they'll also say you can hear it on the back as well, so it's often like, you know, just between the scapula and the back, so that's something that can differentiate it in exam questions. It's mostly asymptomatic as well, so this is the other way around because it's right ventricular outflow. The neonates with really critical stenosis have duct-dependent pulmonary circulation. Okay, so the blood's going from the aorta down the ductus arteriosus into the pulmonary artery. So once that closes, that can then lead to cyanosis in the first few days of life. Okay, it's quite rare to have critical aortic stenosis, critical pulmonary stenosis. Yeah, so sorry, what commonly causes aortic stenosis in a baby? So it is more congenital causes, so more like deformities like a bicuspid valve, or just fused valve leaflets. Okay, so that it still might be tricuspid, but they're just fused. That's why in kids the balloon dilatation is often enough to relieve the obstruction, because it might just be fusion of the valves. Obviously things like rheumatic heart failure, other things that would cause aortic stenosis haven't happened yet, and in older adults it's most commonly ischemic heart disease and calcification that causes it. Okay, so yeah, in kids more commonly bicuspid or just fusion. Yeah, so pulmonary stenosis is also treated with just transcatheter balloon dilatation as well. Often these lesions might not need any treatment at all. You know, they might just have an asymptomatic murmur, and they'll just be followed up in clinic every so often. They'll have echoes. They measure the gradient across so I know in aortic stenosis especially, the gradient from the left ventricle to the aorta, so that should be 0. If that gradient gets higher and it's above 64 millimeters of mercury, that's when you'd start to do an intervention. Okay, so that's just one of the ways that they use to measure it. So, okay, outflow obstruction in a sick infant then. So I kind of talked about the severe aortic stenosis. So talking about coarctation of the aorta then. So this is completely different than adult type coarctation of the aorta. Okay, so adult type is where you get your radiofemoral delay and the systemic hypertension in the right arm. Okay, so that's generally gets worse with age. So it generally presents in later life. The treatment of that in later life is just a stent insertion, just to narrow that, to widen that narrowed bit, and that can be done as well through a cardiac catheter. In a neonate, in a sick infant, this coarctation is commonly caused by the duct tissue from the ductus arteriosus, kind of just circles around the aorta, the point of insertion. Okay, so when that duct goes, that causes the aorta to constrict, and obviously that's a massive problem because you're getting an obstruction of your left ventricular outflow then. So this is one of those lesions I said that it is dependent on that duct. So when that duct closes, that's, you know, you wouldn't have anything before the duct closes. As you can see in the pictures, the flow is still going through okay in picture A, but as that duct closes, you get massively constricted flow going through there. So this is something that typically presents about day 2 when that duct closes. So they'll be absolutely fine in their newborn exam, and then take BAM, circulatory collapse, no femoral pulses, really sick baby, and they can actually get metabolic acidosis with this as well. So management of that is A, B, C, D, E. You want to resuscitate them. You want to start a prostaglandin infusion. So remember, prostaglandins keep the ductus arteriosus open, whereas NSAIDs cause it to close. Okay, so if you have a persistent duct, sometimes we use indomethacin to close it, which is just an NSAID. So make sure you get those two the right way around. So prostaglandins keep it open, prostin infusion. That often comes up as an exam question as well. In a moment you can panic and say the wrong one, the wrong way around. So prostaglandin is open. You would do early surgical intervention in these babies as well. This is quite a critical lesion. Okay. So on to left to right shunt then. So VSD is the most common one of those. So small VSD can cause absolutely no problems at all, can actually close itself. But it does cause a really loud murmur. Okay, so the smaller the VSD, the louder the murmur. That's because, as I said before, the murmur is due to that really turbulent blood flow. So with a tiny hole, you've got loads of blood trying to get through. Remember, you've got really high pressure on that left side. So as that blood is trying to gush through to the right side, which is lower pressure, you're getting that really loud murmur, loads of turbulence going on. So as I said, closes spontaneously. The only thing you want to do is encourage good dental hygiene. That's just to reduce the risk of infected carditis. Okay, so making sure that you put that point across to kids' parents. On the flip side, a really large VSD, so massive hole, it's just easily flowing through. You know, there's not much turbulence there. So you get quite a soft pansystolic murmur. Sorry, the murmurs are pansystolic as well, because the blood flow is just going constantly. You know, even in diastole, the left ventricle pressure is still higher than the right. That blood is always being pushed across. Okay, so that's why you get your pansystolic murmur, and it's at the lower left sternal edge, so more towards the apex of the heart. Okay, the loud P2 that you can get in VSD is because of pulmonary hypertension. More blood flow on the right side, more blood flow to the lungs. That's when you start to get a loud second heart sound. Okay, on chest X-ray, you might start to see signs of heart failure, because they usually present with heart failure about a week old. Okay, so a small one will have barely any symptoms. Large VSD can cause quite a lot of problems. Okay, so they'll start to present with the, as I said before, tachypnea, poor feeding, recurrent chest infections, faltering growth, about a week of age. At that point, you start them on diuretics and captopril, which is just the ACE inhibitor of choice in kids. I think it's because it comes in liquid form, so that's the one most commonly used. You also want to make sure that you give these kids lots and lots of calories. Okay, so they're not eating very much because they get a bit breathless when they're eating. So you want to make sure when they do eat, they get enough. So you want to up that calorie input. This is also corrected quite early, so about 3 to 6 months of life, you would generally do surgery on these ones. It can't really be fixed with cardiac catheter either. You'd mostly need surgery to fix this. Okay, so then ASD. So we've got two types. Your secondum is the most common. So you can see that in picture A. That is just, it's like bang in the middle of the atrial septum. It's not affecting the valves. Blood flow is just going straight across, left to right. So the primum is the one in picture B. So that involves the valves as well. It's actually a partial AVSD, a primum ASD, because it involves the valve. Mostly I would focus on the secondum one because that is 80% of these lesions. You know, that's the most common one you're going to get. So as opposed to VSDs, ASDs are generally asymptomatic. Again, people might not even know they have one. You get that ejection systolic murmur at the upper left sternal edge. Okay, so this is another differential for pulmonary stenosis, aortic stenosis, all got that ejection systolic murmur. Okay, the murmur of this, however, so in pulmonary stenosis, aortic stenosis, the murmur is due to that blood flow pushing against the valve. The murmur in this is because of the left to right shunt is causing loads of blood flow through the pulmonary valve. Okay, so this is actually pretty much just the murmur of increased pulmonary blood flow. So kind of that's why it's so similar to pulmonary stenosis. It is just the increased blood flow across the pulmonary valve. Fixed and widely split second heart sound, that's again just to your pulmonary hypertension. Just note that the partial AVSD, so the primum ASD, has a different murmur. Okay, so you get a pansystolic murmur because of the involvement of the valves. Then you get a component of aortic regurg as well, so you get pansystolic. Treatment is generally with cardiac catheter. So this little device, you know, this picture of in the bottom left, and this is the device they put in. So they just go in with that all folded up. They come up the IVC into the heart, they go across, basically just push like this, and it just sits on either side of the septum. So it can, in a secondum especially, you know, it can just sit on those two little bits of septum and just close off that. It's usually done about age 3 or 5. Because kids are asymptomatic, you know, it's not urgent to close it. And also you don't want them to outgrow the device. Okay, so you generally do it when they're a little bit older. With a partial AVSD, you can't put this in because the valves are affected, and generally the lesion's a bit lower down, so there's no lower septum to attach that device to, so you need surgery in that case. Well, so PDA, just that the duct, so it generally closes at about 2 to 3 weeks of life, so it's termed a PDA when it's failed to close a month. Okay, so it generally classically presents with this continuous machinery murmur under the left clavicle. Okay, so just the blood flow is always going across it. Aorta is quite high pressure, blood flow is always going across from the aorta to the pulmonary artery. You can get a collapsing or binding pulse with this as well. It's usually asymptomatic too. Can be a cause of heart failure if it's really big. Generally, it's asymptomatic and you might not even notice it. If it's sorry, internet's being funny. If it's only a small lesion, you might actually be able to get away with sorry, if it's a small lesion, you might be able to get away with indomethacin. Okay, so this is what I was saying before about the NSAIDs being used to close the patent ductus arteriosus. So if it's only small and you notice it quite early on in life, you could try indomethacin. It's just a type of NSAID. I'm not sure why it's the one used, but generally indomethacin has 2 uses that I'm aware of, and that is to close PDAs and in hemicrania continua. Okay, so 2 good things to note when you use that. If it's bigger, causing problems, you can just close it with a cardiac catheter device about a year of age. So you can see on this chest x-ray, they just insert like a little coil. So it's just like a coiled spring almost that just bridges it and closes it off. Okay, so then cyanotic heart disease. So this is when the blood flow is going the other way, right to left. So your 4Ts are generally the most common ones. I would probably focus on tetralogy of Fallot and transposition of the great arteries. Okay, so the others, just to be kind of aware of, is your truncus arteriosus. So that's what's shown in this picture, where you've just got like almost like a combined outflow tract. So you're just getting mixing of the blood. And tricuspid atresia. So the tricuspid valve just hasn't formed at all. So that can cause stenosis. Okay, so I'm just going to kind of focus on tetralogy of Fallot and transposition. They're the ones that most commonly will come up, okay? So I always remembered it by the mnemonic PROV. So you can see it in this picture down in the left as well. So you've got narrowing of right ventricular outflow, pulmonary stenosis. You've also got right ventricular hypertrophy. Because that outflow has been narrowed, the right ventricle has to work a bit harder to overcome it, so it hypertrophies over time. In the uterus, you've got this overriding aorta with a really large VSD. Okay, so those two in combination cause this blood flow so the blood from the right to then go into the left. So blood from the right ventricle is going out into the aorta. Okay, so that can cause cyanosis. So mostly diagnosed antenatally. Typically it presents with these what's called TET spells. So it's just like periods of severe cyanosis. There'll be no doubt about it when it happens. SATs can drop to like 50s, 60s. The child will literally turn blue, okay? Happens when they're feeding, when they're crying, upset, okay? You'll see their lips turn blue and their fingertips mostly as well, okay? They can get clubbing of fingers and toes, good differential for clubbing, but generally only in an older child, okay? So this is over time of being cyanosed that you would start to get this. The murmur is loud, harsh ejection systolic murmur at the left sternal edge, okay? So all of these, as you can see so far, have been systolic murmurs. So it's kind of learning the what differentiates them all, okay? So don't rely on just being able to see a murmur and go, that's what it is. You need to know some features that differentiate things, kind of when things present. Chest x-ray is apparently a boot-shaped heart, which is a bit unconvincing, but it's just this shape because of the right ventricular hypertrophy is literally just pushing the apex up, okay? It's corrected with surgery about 6 months of life. Some babies can get really cyanosed with this and it can be really distressing. So they'll generally do what's called a BT shunt. So that's just like a tube connecting the pulmonary artery and subclavian, and that's just allowing blood flow from the aorta to go into the pulmonary artery, so allowing blood flow to go to the lungs to be oxygenated. That's just a temporary measure until definitive surgery can be done. They can also balloon dilate the right ventricle outflow. That's another option, but generally BT shunts is done. Just to note as well that if they have a BT shunt, they will then have a continuous murmur, and it is generally under the left clavicle. Okay, so just something to be aware of. It might sound like a PDA murmur. Okay, so if you know they have tetralogy but they have this weird murmur, it could still be tetralogy. Okay. Sorry, just to mention as well with the TET spells, in an older child, they might get them when they're exercising as well. You get that typical, they squat on exercise, which relieves the cyanosis, okay? That's because when they squat, the femoral arteries kink, which causes an increase in systemic resistance. So just diverting that blood flow back over to the right-hand side to perfuse the lungs again, okay? Don't know how to do that. It's very clever of them. Then transposition is the other cyanotic one that I think you should definitely know about. So it's just when the aorta and the pulmonary artery are swapped. Okay, so the aorta is going to the right ventricle, pulmonary artery to the left ventricle, and you've just got two parallel circuits of blood. Okay, so the deoxygenated blood is never going to the lungs to be oxygenated. It's just continuing to go round and round the body. Okay, so this is one of those duct dependent lesions as well. So the only way that the blood is mixing is through the ductus arteriosus. Okay, so it's dependent on that. So it isn't usually picked up before on antenatal scans, but it could just present with cyanosis about day 2 when that duct closes. This defect is incompatible with life. So really when that duct closes, you've only got a matter of time to save them, okay? There's usually no murmur with this because blood flow is not turbulent, it is just going round in parallel circuits, okay? Chest x-ray is an egg on its side, apparently. It's unconvincing, there you go. So treatment of these babies is with an immediate prostate infusion to keep that duct open because that's what they're relying on. So if you already know about this lesion before they're born, then you need to start the prostate infusion immediately once they're born to stop that duct closing, okay? As you can see in the picture, there is often a coinciding ASD, which is a bit of mixing. In babies where this isn't there, they might do a balloon atrial septostomy, which basically they just perforate the atrial septum and make an ASD to allow some more mixing. And then they have the definitive arterial switch procedure as a neonate. So generally in the first couple of weeks of life, they're going to have this quite big surgery to fix it. Okay, we're on the home straight. So just quickly, rheumatic fever. So this is really rare now, especially in the developed world. Just something to be aware of. It can be a cause of Murmur, aortic stenosis, mitral stenosis, more in older people, but it is generally kids who actually get the infection. Okay, so it's an autoimmune response to group A strep. So generally comes about 2 to 6 weeks after a throat infection. Okay, that's why we give 10 days of Pen V with a sore throat because we're really trying to prevent it going any further than a sore throat. Treatment is with rest and NSAIDs. Can lead to heart failure as well as all the murmurs that it can cause. So yeah, it's just important to treat sore throat early and completely to prevent this, okay. Infective endocarditis, again, pretty rare in kids and in this country, but just to be aware that congenital heart disease is at an increased risk. So all those holes in the heart, the VSD, PDAs, all increase your risk. Also the prosthetic material increases the risk, so all these coils and stents are putting in. So you really need to make sure we encourage good dental hygiene in all these kids with heart disease. Most common organism is strep viridans, getting all the same signs as in adults. So the main thing to look out for is if someone has a fever and a change in a heart murmur, then you're going to be suspicious of this. They are very wary of it in kids with known heart disease. Okay, so you do 3 sets of blood cultures, and the gold standard is your transesophageal echo. So you'd see vegetations in the heart with that echo as well. Treated with penicillin and gent, and you do have to remove any infected prosthetics. Okay, so that can be quite a big problem in these kids. If you are going to diagnose them with this, you need to be sure. Okay, Kawasaki disease as well. So this is a vasculitis. 80% that get it are under 5. It is a self-limit infection, only lasts a few weeks, but if you don't treat it, it can cause really severe cardiac side effects, okay? So you can get myositis. We're concerned as well about coronary artery aneurysms, okay? So that can lead to an MI. So as soon as you're suspecting this, you want to treat it with IV immunoglobulin, so obviously they're going to be admitted, and aspirin. Now, this is one of the very few times that kids will be given aspirin. Okay? We don't normally give aspirin to kids under 12. So I always remember it with the red Kawasaki motorbike, just because it is red eyes, red mouth, red hands, red feet, which generally after a couple of weeks the skin will start to peel on, and this red rash, which can be any sort of a rash, it's just a red rash, all different forms of it, and then the cervical lymphadenopathy. So basically everything's red, red motorbike, Kawasaki. okay? Any kid who's got a fever for more than 5 days, you want to be wary of this, okay? That's when your like alarm bells are going, especially in an exam question when they say that it's been a 6-day long fever, okay? That's not right. Shouldn't be having a fever in a kid for that long. Cool. Okay, so that's the end of my PowerPoint. Just that's the textbook I use, and I've always used it for peds. It's really quite useful. It simplifies everything, but yeah, it tells you everything you need to know. And the pictures are great. So I do have a quiz. If I'll just get that up for you now, if you would like to do it. It's just a little short one, just to go through a few things. It's always nice to like consolidate afterwards. I'll hang about afterwards for questions as well, if anybody has anything. So you might have some questions after the quiz as well. So if you want to just get your phones out. So ready? So Down syndrome, what's your most common lesion? Well done. Okay, so while you can still get ASDs and VSDs, and they're common, but the most common is ADSD. Okay, so that's what's going to be your exam question link. Okay. Okay, so you got a 1-week-old baby coming with faltering growth, difficulty feeding, shortness of breath, a soft pansystolic murmur can be heard. What do you guys think? What's the most likely lesion, do you think? Yeah, you're all very quick. Okay, so VSD is right in this case. So this is a baby presenting with heart failure. Okay, so do you remember I said heart failure after a week of life is generally due to increased pulmonary flow. So that's a left to right shunt. Okay, so all of these are left to right shunt, but it's a VSD because of the murmur. Okay, so that pansystolic murmur, do you remember the continuous blood flow across? And it's soft because it would have to be a large VSD to cause heart failure. Okay, so do you remember you get the soft murmur with large and the loud murmur with a smaller VSD? Okay, so what are you going to do about it? Because this is the definitive management, sorry. Yeah, well done. Okay, so while you would use captopril, ACE inhibitor, and diuretics, also never forget your increased calorie input, okay? The definitive management is surgery, and it's done quite early because obviously this baby's in heart failure, okay? We're not leaving them for ages. Oh, and sorry, just remember VSD has to be done by surgery, not cardiac catheter, okay? Okay, so an infant which is turning blue on feeding and when they're crying, what's your primary differential? What do you really want to rule out first? Yeah, well done. Okay, so this is that classic question about cat spells, okay, is what I'm trying to describe. So turn blue when they're feeding and when they're crying mainly. The fact that they're turning blue says that this is a cyanotic heart disease, okay, so that already rules everything else out. So tetralogy is the answer there. Perfect. Okay, so this was a previously well 2-day-old baby that becomes acutely unwell and has no femoral pulses. What are you thinking? Yay, you got it. Okay, so as I was explained before, so coarctation of the aorta in neonate is because of that arterial duct tissue circling. Okay, so they might examine completely normal, completely fine at birth. All of a sudden, when that duct closes, it causes the aorta to really severely constrict as well. Okay, and they get really unwell. And the key thing in exam questions is no femoral pulses. Okay, so there's barely any blood flow getting through the aorta. Okay, so that's why they lose those. Well done. Okay, so baby with transposition, what management do you need at birth? What do you want to give immediately? Yeah, well done. Okay, so always remembering that prostate infusion, prostaglandins, keep it open. Okay, and you need that duct open to keep circulation going. Okay, well, 3-year-old child, ejecting systolic murmur, upper left, sternal edge. What's most likely? Okay, so a little bit more split. These are the ones that get quite difficult, okay, because you don't get much information in an exam question, do you? Sorry, got the window open, it's extremely warm. These are the ones that you don't get much information, and in real life, you would do an echo to diagnose it, okay? So this is just playing the exam game. So things to pick out in this is 3-year-old child, and they've been completely well, they're asymptomatic, okay? So that's ruling out any serious big defects, okay? So the ejection systolic murmur at the upper left sternal edge, okay? So the ejection systolic murmur could be pulmonary stenosis, aortic stenosis, or an ASD, okay? Small VSD would be the lower sternal edge. PDA, do you remember you get that really continuous, like machinery murmur under the clavicle? It's generally described as, okay? So a bit higher up. The PFO, you don't get a murmur at all, okay? So there's no flow murmur with that, okay? So healthy 1-year-old child, they've got a viral infection and they have a soft systolic murmur on the sternal edge. What do you think you're going to do? Yeah, okay. So this is a bit of a tricky one, okay? So as I said before, do you remember you've got your innocent murmurs as well? So while I wouldn't be completely confident saying this is fine, we're going to leave it. This is a healthy child, okay? They don't normally have any thing to worry about, any signs of any heart disease, okay? And they have got a viral illness at the time, which makes these innocent murmurs louder and more prominent, okay? So you're going to bring them back in a few days' time or even a week when they're better, okay? In the grand scheme of things, that's not a big delay compared to the wait to be seen in Paediatric Cardiology, okay? Probably will end up, you know, if they still have a murmur when they come back when they're well, then you're going to refer them to Paediatric Cardiology. You're not doing any investigation by yourself, you're sending them straight there. Okay, so left clavicle, continuous murmur. So what is it and what's the management? Yeah, well done. That was a tricky one. Okay, so that's what I was saying about that's a different murmur than the ASD. Okay, so continuous machinery-like murmur under the clavicle, so a bit higher up. And it can be referred repaired with cardiac catheter. Okay, so that's when they put the coil in. Do you remember I showed the X-ray of it? Well done. Okay, what medication should be prescribed for a boy with family history of hook'em? Okay, this is something I just briefly mentioned, so yeah, well done. Okay, someone's listening. So you want to give a beta blocker in these patients, okay? So anyone with family history of hook'em gets a beta blocker. That's just to increase the effectiveness of the contractility of the heart, okay? So it slows the rate down so you're contracting more efficiently, okay? Also as well, always doing ECGs and echoes, monitoring this to make sure that there's no severe systolic dysfunction. Okay, it's a 2-year-old boy, 6-day history of fever, and these findings, you're going to get a picture. What's the diagnosis? Yeah, super quick, well done. Yeah, perfect. Okay, so as soon as you see that 6-day history of fever, you should be thinking Kawasaki disease. Okay, well done. Okay, last one. So, management for the previous patient involves aspirin. Why is that not given to under 12s? Not sure if I actually mentioned why, but it is a classic question. You all got it. Perfect. Okay, so this Rey syndrome just affects the liver and the brain. Okay. The ultra rapid metabolism, just to note that that's coding. Okay, so we don't give coding to under 12s because it can be metabolized really quickly to morphine and cause an overdose. So definitely don't do that. Well done, everybody. That was really good. I'll stick around for a little bit if anyone has any questions. Yeah, thank you all very much. Again, well done for being here. I don't have a survey link, but I'm sure it would put on the chat to the group. Sorry, so if you could fill that in, I'd be very appreciative. Thank you all. And anytime you have questions, I'm more than happy to answer. Good luck.